people. So on with the first session. I'm personally really looking forward to this session. It's such an important topic across the whole of our scope of our practice for our patients and for our staff. I don't need to go into sort of details of the poorer health comes for those children that are sadly living in poverty, deprived, of colour. But there's also a lot of research that shows that those more inclusive organisations fare better in their health outcomes for their patients that they served. And so I'm really delighted that we've got a range of speakers in this session who are going to share some thoughts and some insights. There'll be some things for us to think about, hopefully some tips for us to think about in our practice, as well as some inspiring stories. I'm personally really delighted, and that rightly so, we're going to kick it off with hearing from those who we work to serve, our patients. So RCPCH and us is the Children and Young People and Families Network of the Royal College of Paediatrics, and they're the absolute go-to experts in child and youth engagement. It was established in 2015 and has worked with over 8,000 children and young people, and they've volunteered over 1,400 hours in the pandemic to support activities, which is just phenomenal. And they've done things sort of condition-based stuff based on asthma, epilepsy, to delivering improvement training on engagement, developing resources, thinking about young people from the LGBTQIA+ backgrounds, and then they've even been involved in writing START assessments for those of you that are about to do your START assessments. So we're going to hear from some views from young people and young adults from the RCPCH and us group on their reflections on health inequalities and inclusive health services and what those look like to them. And then later on at the end of the session, we're going to hear from a different group of young people about how we might support their engagement in health. I'm absolutely delighted that Emma Sparrow, who is the Children and Young People's Engagement Manager at the RCPCH, is with us to introduce the videos. And her work and ethos has always focused around community activism and involvement, and she's got a real passion for promoting and protecting children and young people. I'm absolutely delighted that she's here. So Emma, over to you to introduce the videos.
Thanks so much. Yeah, it's really good to be here. Let me just see. I'm not sure if my camera works. Doesn't always work. There you go. It's really good to be here. So as you've said about being online, it's been a little bit more challenging of late to speak to children and young people and really understand what they're thinking about things around inequalities in health, but also how to create an inclusive service. So we reached out to our children and young people. Some we met in person, which was really exciting. Some sent us their views and some sent us their audio, and you'll see that whilst children and young people have a really strong sense of what's equal and fair, talking about that in terms of a health service can create some confusion. So I'll get James to play the video and then I'll just pick up with a few points afterwards.
We can't hear the sound of that video. Oh.
I think we might just need to restart so that we can pick up the audio that the young people are saying. So I don't know if we have to share the screen with audio.
What are the health inequalities that young people face?
Health inequalities mean to us health in a different way. Health equality, qualities that are in your health.
I lived in London for years and I never had any problems getting a doctor's appointment with local GPs and specialists. And now I've moved to the countryside in a village and I struggle to get an appointment and there's no specialist for a long time and I have to wait for a very long time.
Equality is in like treating everyone right and don't come to me for help because I am not the person.
Is that as in like fat shaming people?
Yeah.
Ethics? Is that what it all is now?
Ethics?
The treatment of the variation of people from different backgrounds.
A friend of mine has been on the waiting list for autism, for getting checked for autism, and I have another friend who's on the exact same waiting list, but they're both from two very different families. One is more affluent and one is considered more poor, and the person who is more affluent managed to get checked first, even though they've been waiting for less amount of time. And I don't think this is very fair, but I don't know why that is, but I have a feeling it's to do with wealth and class and stuff like that.
Well, when I think of health inequalities, I think it's like people coming from different backgrounds for inequalities, coming from different like parental backgrounds, if they had parents, if they have both their parents still living with them, and then health is if you're in a good shape, you're mentally well, you're physically fit, and yeah.
What would make a more inclusive health service for young people?
Inclusive health services have team building activities, different rooms for different ages, themed rooms for different interests, and do training for staff on how to talk to young people.
A good thing to change now would be the way we are treated. So not like a child.
They should be asking what's important to us.
It should be that care is all about the person.
So we got lots of ideas from Peer Youth, who are Southampton based, who really helped us to think about, what we wanted to include in that video, as well as some of the RCPCH and us young people from across the country. Really, as I said, they understand and they have really clear ideas around rural access, around LGBT health needs, around making sure that actually people from different socioeconomic backgrounds are treated the same. But what they found quite difficult to think through is actually what would that translate to in a service that made sense for them? Because lots of things that they were talking about came back down to the communication aspect and being treated as equals, being given information in a way that you can understand, but also, thinking through actually how that environment and space works for them, particularly as we hear lots of different sessions that we do around age and stage, and the fact that actually they don't always feel that they are treated equally in the service as maybe adults, or if they're younger children, as older young people might be, or, where people, maybe talk to their parents and carers rather than speaking to them. So lots of what came out from the discussions really boiled back down to, being understanding of different backgrounds, different cultures, different identities, but also being able to speak to people as equals and make sure that actually that they feel part of their patient-centered care and also service shaping coming from their, their different backgrounds and experiences. So the video at the end will give you a few of their tips, and I'll drop some links into the chat so that you can see where some of their other thoughts have come through, particularly from the Paediatrics 2040 programme and from COVID Book Club. So I'll hand back to Kate, I think.
Yeah, lovely. Thanks, Emma, and thank you very much to all the young people that participated in that. So next up, I'd like to introduce Jenny Douglas Todd, and Jenny is the Joint Director of Equality and Inclusion for the NHS E&I. She spent over 20 years working in the public sector, joining the civil service at the Home Office, where she was for 4 years, before joining the police and research for the Independent Police Complaints Commission. And then in 2009, she became the Chief Executive and Monitoring Officer for Hampshire Police Authority and subsequently the Hampshire Police and Crime Commissioner. Jenny was one of the NEDs here in Southampton, and I was fortunate enough to work with her on some pieces of improvement work at that time, and I'm absolutely delighted that she's here today to share some thoughts for all of us on health and racial inequalities. So Jenny, over to you. I know you'd like us to move your slides on, so if you just give us a nod when you want a slide moved on, that would be super. Thank you.
I will do, and thank you very much for that, Kate, and lovely to see you again and to see the familiar surroundings of University Hospital Southampton boardroom, where I haven't been for a while. So great to be here this morning. As Kate says, my name is Jenny Douglas Todd. So in addition to being the Joint Director of Equality and Inclusions, I am also the Designate Chair for the Dorset Integrated Care System. And I apologise for the photo that is on the screen. That was taken at the start of Race for Head last week, which I'll tell you a bit more about later on. I'm going to be talking about racial equalities in the healthcare workforce. That's predominantly where I'm going to be focused. It's been fascinating, though, to come on after RCPCH's video and hear what they've been doing. Obviously, as Director of Equality and Inclusion, the work that I cover is across the equality and inclusion agenda, so across all the protected characteristics. And some of the conversations that were on the video are very reminiscent of the conversations that I hear from young people. And interestingly, are not as representative of the conversations that we often hear from older people and particularly people in the NHS workforce. And so part of what my job is to try and get those conversations to happen more naturally, because actually if we can engage in those conversations, it will develop a greater understanding for us about what we need to do around inclusion, and also then help us to design our services and the workforce to meet that, to ensure that we can match that. So, so really great to hear that. And in preparation for today's conference, one of the things I was doing was just kind of researching a bit about peer and what you do. There was a piece that was done at the peer conference last year, 2020, which I think Kate had a hand in terms of that input, and it was called Liberating Structures. That for me was really interesting, because one of the things it's talked about was about simple methods that make it easy and practical to engage and include everyone in shaping the future. And that really, that's what equality and inclusion is about. It's about how do we involve everybody in shaping not just the delivery of services that we have today, but the future moving forward. So, so that's going to form a theme of what I'm going to be talking about today. And I'm going to start that just by looking a bit around some research that was done in 2019 by the Intergeneral Paediatric Services and the workforce supporting that. So that was the study that was done in September 2019. And what it found was that, that the General Paediatric Service itself was fairly stretched, that there was a great deal of variation in the services across the UK, that the health needs of children have changed drastically over the past 50 years. And that was encompassing moving towards more complex and comorbid conditions for children. So for example, things like diabetes, obesity, mental illness, and also safeguarding concerns. So really complex environment, children with complex needs, ever growing in complex needs. And then consequently, we need a workforce then that can work with that, respond to that, and enable and support our children who are going through these systems. But alongside the comorbidity of children, the research also found that the workforce itself is under pressure, and we know that currently that we have lots of pressures on the NHS workforce in particular, but the broader integrated care workforce, which I'll touch a bit more on later, partly due to COVID, but also due to the winter pressures that we're facing, and of course the standing up of elective services. And for the first time in decades, we have, and this is a situation that is occupying part of my thinking in Dorset, where we have people waiting for 104 weeks now, so over 2 years for operations. And that is knowing that people are sitting out there with harm and trying to work through how we struggle with the demising workforce, particularly in the care sector, and the workforce in the health sector that are facing pressures, the additional pressures that I mentioned. It is quite mind-boggling to think about how we're going to turn this around to ensure that we are giving people what they need. And then with a specific focus on children, we know that child health is worsening, is certainly in terms of health outcomes. And as we saw very eloquently on the video, that there's increasing inequality in the UK. So what does the workforce mean then for paediatric services to address that? Well, it means having the right number of staff with the right level of expertise to deliver the quality care that we would want our paediatric patients to be having. But the research that I mentioned in 2019 found that there's a 10% shortage of staff on the medical rotas in paediatrics. So that brings a real challenge. And we also know from research that the diversity of the workforce needs to improve. We know that generally. And I will, when I go a bit further, we'll talk about some of the workforce race equality standards research that we do, that we publish on each year to just bring some of that to life. What I thought I'd do before that, though, is just to talk a bit more about race and the key messages that it brings. So let's look at race equality and the healthcare workforce. It's a multifaceted, some progress already made alongside some aspirational targets for the future. And the health needs of children are changing drastically along with the socioeconomic influences that are connected. Age continues to amplify. So the NHS workforce faces similar flux in terms of political, media and social influence. And some colleagues feel we cannot fix deeply historic and contentious and entrenched societal issues within a workplace. But given that the NHS is the largest employer in the UK and the largest and most diverse employer in Europe, I do believe that we have a duty to see how we can fix some of these issues. Because with 1.3 million people in the NHS, a further 1.2 million people across the care sector, that is a significant proportion of the population. So they don't just work in health and care, but they are also part of our populations. So they will be the parents, grandparents, siblings, etc. of the people who will be going through the general paediatric services, in addition to making up part of the workforce to provide that care. So it's really important that we are addressing it and not just saying, well, it exists in society, so how can we change it? Because we have an opportunity to influence what society is doing. One of the discussion points that I thought it might be useful to come to will be is around will we still refer to ethnic minorities working with children and young people from locations where their ethnicity, culture, language and society is now a majority? And one of the reasons I wanted to talk about that is because I did a talk last week as part of Black History Month. And it was a talk in North East Yorkshire. It was virtual like this. It was in the North East and Yorkshire region. It was very much focused on ICSs. And the piece that I decided to do was to talk about expanding beyond the UK context, bringing an international best practice into the equation. And looking at the peer conference last year, I see that you had people from all over the globe that were participants to that. So similarly, that might be the case for this year's conference. And I think there's a lot that we can do to learn from elsewhere. Obviously, as the biggest health organization in the world, then there's some things that we can contribute. But the learning that I took forward from an international perspective, and the reason I decided to focus on that for the contributions that I made last week, was because there are some systems where they have operated integrated care for over 25 years. And what we find with those systems is that they have managed to shift the load, if you like, from the need to build more acute beds in hospitals to actually doing things with communities, in communities, for the communities. And two of the places that I mentioned as part of that were South Central Alaska, with the Alaskan Native community, and also the Bronx, Montefiore. And both of those are examples of majority populations of people of colour. And in the UK, we often talk about minority communities without recognising that actually we do have some places in the UK, particularly in the Midlands, where we have minority people of colour in the majority population, so specifically places like Leicester. So there is something about us challenging ourselves, challenging our concepts, challenging our narratives around how we look at people, particularly from an ethnicity perspective, and how we therefore then not just engage in the discourse, but how we use that understanding to shape the world and the delivery of paediatric services as we move forward. I believe our NHS can model best practice for our people and our patients alike, and that includes our workforce. And one of the things that we did last year, excuse me, was published this year, was that we looked at the medical workforce race equality standard. And that has set the baseline down for clinicians around what that workforce race equality standard looks like. And the reason we did that is because we were hearing recurring themes around partly what the medical workforce looks like, but also around those experiences. And we know that from 6 years, almost 7 years now, of reporting on the workforce race equality standard, otherwise known as the RES, that the indicators themselves have been quite difficult to shift. So one of the things I did when I joined NHS England and Improvement last year, in September last year, was my team were just getting the workforce, the RES data ready to publish for 2020. And it was sent to me to sign off. And when I looked at the data looked actually quite reasonable, but there was just a nagging feeling in me about the data in comparison to previous years, not just the 2019 year. And so I asked the team to pull some the data together for me over the past 5 years so that I could see what that looked like. And what was clear from that data was that of the 9 indicators that we have on the RES, only 2 of them had increased over that 5-year period. All the other indicators had either stayed the same or declined. And so I asked the team to produce a report looking back over the 5 years, and brought in Anton Emanuel to come in, who's a neurological gastroenterologist, to come in and head up the RES team. Him working with the team, we were able to produce the report that showed the kind of journey of travel of the RES over the 5 years of reporting. It was actually 6 years of report, but the first year was used as a baseline. And that's what we've done with this medical workforce race equality standard, which we call MRES. And what we found from that report this year is that BME doctors report a worse experience at work compared to white doctors. the trend from the whole career path from medical school to consultant level is similarly disproportionate. So even when BME doctors become consultants, they report greater levels of discrimination and harassment and lower levels of feeling involved at work. But what's really interesting, actually, but both with the MRES data and the workforce race equality data, is that when you ask Black and minority ethnic staff workforce, whether or not, when you ask all of the workforce about motivation, what you find is that BME staff, the BME workforce, tend to have greater levels of motivation. And we found that similarly with the MRES, that BME doctors reported greater levels of motivation at work. We also see that as the medical workforce becomes more diverse, more must be done to make sure that BME doctors have the same positive experience and opportunities as their white colleagues. And I will pick up a bit when I get to talking about Race Ahead around how we think some of that should be done. As the NHS is moving post-COVID recovery, we have a greater reliance on internationally trained staff. I don't know what the figures are for paediatrics, but generally there's a reliance on internationally trained staff, particularly for doctors and nurses. And we therefore need to make sure that, that we're not just bringing people in, particularly at a time when we know they might be needed by their own healthcare system, but that actually we are making them feel welcomed and included, and that this is a place where they can come and thrive. The consequences of racism are likely to have a toll on the staff affected, but also the wider workforce and patient outcomes. So 41.9% of medical and dental workforce in NHS trusts and clinical commissions groups in England are from a BME background, compared to 14% in the wider population. So you can see the NHS is heavily reliant on people that look like me, people of colour, to deliver services, and therefore we have a greater responsibility to make sure that we are doing what we can to erode racism, and even better, to become anti-racist. So I'm going to move on a bit from the MRES to talk a bit about the workforce race equality standard, and then I can come back in a bit if that is wanted to talk a bit more about the MRES. So the workforce race equality standard is our benchmark for inclusive recruitment and promotion. And as you've heard, it's supported by the MRES that we've just developed. And in can we go to the next slide, please? In 2020, this slide focuses on London, and it focuses on the board representation in London. And you can see that in 2014, BME members made up 16 in terms of board membership, and by 2020 that had climbed to 36. And this is one of the 9 indicators that I've told you that that I mentioned earlier that has changed. So we have actually seen an increase in board level membership by Black and minority ethnic people to around 14.7% now in 2020. Really good news, and good news that we've shifted that. But the discerning thing about it is that that statistic is made up primarily of people at non-executive level. So Kate mentioned earlier that I was Deputy Chair of University Hospital Southampton, and prior to that was non-executive director. And it is bringing people in at that level that has shifted this data to 14.7. So what we need to do more in terms of increasing the executive level. And it's really important, therefore, that particularly those in the paediatric services, because you're the cohort that we're speaking to today, are looking at what are the things that you are doing? How can you make your workforce more equitable? And how do we ensure that actually we set up an environment where people of all colour can progress and feel that they have a future, particularly in paediatric services. Moving on to the next slide, please. This just demonstrates that in 2020, there were 61 more BME board members across all NHS trusts. And this was an additional 26 executive and 35 NEDs. 19 of those were in London, though, so more to do across the country. And one of the things I constantly say when I'm speaking at events is that I think there's always been a mantra around we need to attract a broad diversity of people so they represent the communities that they serve. But bearing in mind the statistics that I put up around Black and minority ethnic people in the NHS being far greater than the general population, if we just worked on the populations that we serve, it would mean that there are whole swathes of the country where we would be saying that it would not be appropriate for BME people to aspire to be in senior management. And I'm sure that's not what we mean. So in Dorset, where I am the chair of the designated chair of the integrated care system, 50% of our chief execs, NHS chief execs, are Black and minority ethnic, 50% of them. And if I just focus on the providers, then we're over 50%. And that's where we have a really small population of BME people. So I think at the most we would have 5% in some of our conurbation areas. So my thing is to say that that's what we should be aspiring. Individuals who want to progress their career should be able to look and decide that they want to work somewhere and not feel that they just have to be funneled into areas where there are high populations of BME people. And why is that? Because if we make improvements for one, we make improvements for everyone. And so it's important that we have an NHS that grows its own, supports its own and flourishes its own so that people can work and lead everywhere. Moving on to the next slide, please. So in 2020, 21% of the staff working in NHS trusts and clinical commissioning groups in England were from a Black and minority ethnic background. And this was an increase from the 19.7% that you saw there in 2019. In a snapshot of general paediatric services and workforce in the UK, the RCPH states that there's still a shortfall of 22% whole-time equivalent paediatric consultants to meet the current acute, long-term and safeguarding and other demands. So some real challenges there in paediatrics. And I guess part of the challenge for you all is to ask you, where do you want to feature in relation to the makeup of the paediatric workforce, and particularly in the seniority of the workforce? So what are the specific things that you are going to put in place to ensure that paediatrics is an area where individuals can excel and really contribute to the delivery of paediatric services? Next slide, please. So I mentioned right at the beginning the race ahead, and I'm just going to give a background as to why we are doing this. So at the beginning of this year, I was reading an article by Muhammad Yunus, who's an economist, a world-leading economist. And one of the things he was talking about was that all economies have had to change during coronavirus because, as we know, people weren't going out, so they weren't spending. And there was a whole range of things that altered our economies. And what they were all doing was working hard to see how they could get their economies back to where they were pre-COVID. And he was provocating that actually what governments should be doing is using where they had got during COVID to actually think about doing something different. Because what he said was that if you look at all economies, they have all reproduced inequality. They have not produced environments that are inclusive and equitable. And so he was saying, let's use this as an opportunity to build back something different, not build back the same that we had before. And one of the ways he suggested that governments could do that was to ensure that every child has a week in their life at school every year to talk about economies, to talk about some of these big picture things, because they are the future. And because children, and we saw from the video earlier, tend to have a more open mind, it's likely that they can come up with ways that we can build our economies for the future that will be more inclusive and more diverse. And so I read that and thought, what a fascinating article. And wouldn't it be nice if the NHS, which is the 4th largest workforce globally, did something similar for its workforce, so that we could actually start the conversations within the NHS around how do we create a more inclusive environment for the workforce, because we know that by having a more inclusive workforce, that we are going to deliver better patient care. So, so my thought was, then why not, let's try it, and let's develop an event where we can actually talk about how do we become an anti-racist environment. And so so it proceeded to do that, and we agreed as the senior team under the People Directorate with the Chief People Officer that we would launch the How to Become an Anti-Racist NHS in October of this year, 2021, because that was also Black History Month, and we thought that would be a good environment to actually launch this. And the idea of Race Ahead was specifically to do something different to what we've done to date. So many of you will be familiar with the kind of anti-racist training that we do. Some of you will have done non-bias training, unconscious bias training, and you will be familiar with various strategies and actions that your organisations take in the concept of being anti-racist. Yet across the 1.3 million people that we have in the NHS, we still have large swathes of predominantly white staff who find it really uncomfortable to talk about race, find it really difficult to even mention the term Black. And if that's happening, it means that they're not having honest conversations, they are not having compassionate, inclusive conversations, and they're not enabling a great space of their workforce to be able to do their best. So the concept around Race Ahead is actually to change that dynamic, and actually to say to the white majority that actually, if we are going to become an anti-racist NHS, we all have to be in this together. Everybody has to be talking about this, because it is only through talking that we can then come up with some actions collectively to address the issues that we face. And there's a real difference between not being racist and being anti-racist. Being anti-racist means that you actually have to proactively put steps in place to ensure that you create an inclusive environment, and that we can enable line managers to be able to create the environment for all of their staff to give of their best and to excel and succeed. And one of the areas that we're focused on as part of the work that I'm doing, so we're overhauling, one of the things I've been charged with for the next 3 years is overhauling recruitment and promotion practices within the NHS, because we know that they how we recruit and how we promote people has a direct impact on what the seniority at ESM and very senior management looks like. So we are overhauling those recruitment and promotion practices. As part of that, we are having a focus on band 6s to band 8 line managers, because they are the biggest cohort of line managers in the NHS. There's 426,000 of them. And they also therefore do the vast majority of the recruiting and promoting. And we know from anecdotally, but also from the data, that line managers play a really important part in whether or not somebody feels they can succeed and are able to apply to the next level. And so if you have, as a line manager, somebody that looks like you're familiar with, that you can talk with, it's likely that you will give them informal mentoring. You'll have the conversations over the coffee machine in the days when we were all working in the workplace environment, that enables somebody to think that actually they could try and do something different. You might give them access to trying additional things so they can expand their skills. But that doesn't always translate to staff that look differently. And I've certainly been conscious of some Black staff groups whereby the staff, the workforce, think that the best way for them to get promoted is to equip themselves to the eyeballs with different qualifications, and then years down the line still don't understand why they haven't been promoted. And when I speak to the line managers are saying it's because they haven't got the softer skills that are required as line management, but nobody's ever had that conversation with the people that they're line managing. So a real challenge for us to do something different. Next slide, please. And so last week, the Race Ahead was opened by Amanda Pritchard. You'll see her there in the picture with the Chief People Officer, Prerna Issar. I led a conversation with the two of them around Race Ahead, their own experiences and the things that we needed to do. On this slide, you will also see that today, so whilst we are here on the peer conference, we have the second session of Race Ahead going on, which is focused on leadership that makes a difference, positively transforming the culture of the NHS through leadership. I would unashamedly plug, if you haven't signed up already, please sign up to Race Ahead, because even if you can't access the sessions today because you're doing this, you will be able to go into the slide. You saw the brain on that previous slide. You'll be able to go in there and access the recordings of the sessions that have happened. I think today is a really good session for leaders. And so I would encourage everybody to try and access that, because I think you'll find some useful tips there of things that you can take into your own practice. Next Tuesday, we are going to be looking at improving health and wellbeing for all staff by reflecting on their lived experience. And so we'll be talking about the staff survey, but also talking about health and wellbeing offers and things that individuals and line managers need to think about. And then the very last Tuesday, which is 26th of October, will focus on strategic approaches to achieving race equality. And again, we will be having individuals coming from other organisations who have actually walked some of this journey already and have some successes in their organisations, coming along also and speaking with us about what they've done, how the journey was and things that they could be doing. And the last slide, please, is just the slide that sets out that in support of Race Ahead, we also have the all of the regions working with us and delivering their own events. So wherever you sit in the country, in addition to accessing the Race Ahead sessions in the morning, you then have the opportunity to visit your region, visit other regions. In fact, it's all available on the platform for you to dip into another region, and they will have events running across the whole of October for Black History Month. So that's the end of the slides. And what I wanted to do was just to kind of end to ask you all to kind of reflect on some of the information that I've given today, and more specifically to ask yourselves, what does race mean for you? How comfortable are you talking about race with colleagues? And what will you need to do to be able to shift that for yourself so that you actually can make some changes within the work environment that you are, so that consequently you can then deliver in a more equitable way for the patients and young people that we see. Thank you very much for inviting me today. I wish you all the best for the rest of the conference, and happy to take any questions. Thank you. Okay, so I don't know if are you going to ask me questions, or do I just look in the chat?
Yeah.
What?
Nothing happening.
Will they give me a sec?
Okay. God.
See.
Can somebody speak? Saying 3, 2, something.
I can certainly see Kate.
I can't. We haven't got any sound.
Oh, right. Okay.
Can you hear me?
I can hear you. And I can see
okay,
you.
fine. It's all right. I can't. It doesn't look like you can on my screen, but don't worry. That's fine. Thank you. I was just sending a message. Jenny, thank you so much. Really, 3 brilliant questions for us to finish on there, and something for us to really go and reflect on. So a few questions that have popped up in the chat and on Slido, if we can use your time. So people noticed that you use the term Black minority ethnic groups, but been reading lots of debates about the sort of the right way, the wrong way to refer to those who are of colour. And so just interested to hear what you think, both in your role and obviously as a person of colour, about those terms and acronyms, and are they helpful or unhelpful, and what might we, and you know, I think that helps actually to ask us, you know, it almost helps some of that question, doesn't it? What does race mean, and how comfortable do we feel talking about it?
Yes, so I think that question will be referencing the non-cred, I call it, but the Commission for Race Equality Disparities report that was done. I can't remember if it's the end of last year, beginning of this year, but it was done recently by government. And just shortly before, it was led by Tony Sewell, journalist, and just shortly before that report was published, the Cabinet Office suddenly put up on their website that we were no longer going to use the term Black and minority ethnic or BAME or anything else. They were moving to the term ethnic minorities, and that was it. That statement was put up. So there was lots of questions going on right across the public sector about what does this mean? Why is it being put up? I mean, it was totally just came out of the blue and nobody understood why it was there. And then the report came out a couple of weeks later, and it was obviously clear it was the kind of run up to the report. And one of the reasons that why we haven't moved to that in the NHS is when that went up on the website, I then looked into what sat behind it. And I suspect it's still there for anybody that wants to research it. So what was there was a map of England, similar to one of the maps that I put up, and the consultation that government had taken, and in fact it wasn't government, but the consultation that the CRED had done on the use of the term BME and BAME. And if you look at it, there were very few people involved in the consultation, but if you look at the where they did the consultation, they were all in areas where there are very, very few Black and minority ethnic populations. In fact, none of the people that contributed to that consultation lived in an area that has a significant population. And so what we have is a government made up principally of people that look like you, Kate, telling people that look like me what we should call ourselves. And we had already decided in the NHS, as part of my role, that we would start some conversation and some consultation on terminology around the third or fourth quarter of 2021, so around about now for this year. And the reason we wanted to do that is because we know that some people struggle with saying BAME. The BAME term, lots of people don't like. I personally tend not to use it. That's why I often say Black and minority ethnic, because I just find it quite dismissive. So we had already decided that we would do some consultation on that in the NHS to see where we could go. And we will do that. We're now going to do that in the fourth quarter rather than third. But there's been a deliberate step, therefore, because the consultation has not involved people of colour, that we will not just revert to that terminology. So we are still using Black and minority ethnic for now. Most of, in fact, all of the reports that we do, such as the RES, refer to BME, Black and minority ethnic. We will engage with the vast majority of people in the NHS around terminology. And once we've done that, we will come out with what we think people want. So that's the kind of very long answer to a relatively short question.
No, but I think it's fascinating, and what you've just highlighted to us is, I think, one of these principles, that it's so important that we should be thinking about how the work we're doing is done with, or even ideally done by, the people that we're serving, and not done to and for them. And I think we're guilty of that, whether we're talking about our staff, as we are here, whether we're talking about our citizens, whether we're talking about patients, and we think we're doing the best thing for them, but actually we're not, because we haven't asked them. And ultimately that's what inclusion is getting their voice and getting them, at the table, heard and involved. So thank you. A question from, I think it was John Rabs in the chat on the screen, saying, is inclusiveness and anti-racist practice part of CQC inspections?
Yeah, really interesting. So it is. And so when I started in role, one of the things I said is, we've got to get the CQC to make sure that, that they're not rating an organisation outstanding where they've got very poor res data, for example, and experiences. And people said, good luck with that, because we've been trying for years and the CQC aren't going to do that. But actually what the CQC do, and Kate, you might be familiar with this from Southampton, is they do actually look at experiences, and they do look at inclusion and division when they go and do their inspections. And if concerns have been raised, they will also do a deep dive to see what that looks like. Now, at this moment in time, you still, however, can be rated as an outstanding organisation for leadership and still have issues in relation to those issues. So there's still work there to be done. But the CQC sit on, I set up a group called the Chief People Officers Equality Advisory Group, started at the beginning of this year, and CQC, Ted Baker, the Chief Executive of the CQC, is one of the members of that group. He sits on there with us, and he is very much into this agenda. He talks every time I've seen Ted talk. Now you might say it's because I'm in the room. I tend to think it's not, but every time I've seen Ted talks, he does talk about inequalities. He's actually quite passionate about it, and he's wanting to find a way to tangibly measure what's going on. And he has also been one of the advocates for us with the Race Ahead. He sits on my steering group that helped to set up Race Ahead. And we had the CPO's Equality Advisory Group on Friday, and all of the members, including Ted from the CQC, contributed to a discussion that we had that was filmed for the Race Ahead platform, but also has made a pledge himself around what the CQC will do to pursue this agenda. And on the, I think it's both on the third week and the fourth week, so the 19th and 26th of October, we have the CQC participating, leading two separate sessions on what they're going to be doing. So I would say watch this space. I think there is commitment from the top in relation to anti-racism and equality, diversity and inclusion more generally. And I think the CQC probably experienced what we all experience, that, that the senior leadership can articulate their commitments to this agenda, but it's how that translates down. And that's partly why we're focused on that 426,000 band 6 to band 8, because they're really critical. If you want to translate down exactly that commitment, we have to get that band on board. So yes.
Absolutely, moving from talking the talk to walking the walk.
Yeah.
So a final question, if we might, just changing tack slightly. This is from somebody anonymous, but I think this is just a really interesting, slightly different slant on this. They were talking at their handover, I think this morning, about a child who was being racist to staff. And how the staff might deal with that. And obviously that's kind of part of the equation for us. So just any thoughts on that for us as the healthcare professionals, kind of tackling that in the workplace, but from the child towards us as staff?
Yeah, so this seems to be a growing issue actually around patients and all their families. And I think with adults, it tends to be the family members that are expressing kind of overt racism to staff. So it's a growing issue. It's a piece of work that we're trying to see how we can stand up in the centre around this, because we are hearing more and more concerns being raised, particularly by ambulance paramedics and general practitioners. So not surprised to hear that children similarly are also engaged in what is, for me, quite a worrying trend. And so a couple of things I want to say. Firstly, I think that all staff need to move from feeling uncomfortable and that feeling uncomfortable immobilizing them, because I know from my own experience that we've had experiences of staff who have been subjected to racism, have had white colleagues standing there who have not stepped in or said anything to the patient or their family. So the Black member of staff has felt very exposed and quite vulnerable and isolated. And later on, the white staff who have been there will come up to them and say, "I'm so sorry that happened. How are you feeling?" Which is great that they're concerned, but actually that's not dealing with the issue when it's happening. And I think there are a couple of things about not dealing with the issues that you're not reinforcing to the patients, whether that be children patients or adults, that behaviour is not acceptable. But you're also not showing proactive support for your colleague. So that's one of the things that we're trying to get out of Race Ahead, because if people feel more comfortable about talking about these things, and hopefully they will become more eloquent around tackling with them. So I think it's really important that it's dealt with. And I think actually it's important that white colleagues respond to children that are making those statements, not expecting the Black staff member to do that, because that has more power. So if I say to a child, if I'm a paediatrician and the child said something racist and I say, well, you shouldn't say that, whatever, the child's probably going to think, well, you would say that because, you know, you're part of the group that I'm talking about. Whereas if you stepped in and said something, then they might be a bit shocked by that. They might be a bit taken back, and they might think twice, because they'll think, well, actually that person looks like me, and they're saying it's not right. So that's the first thing I would say. The second thing is that I think what we need to do as organisations is to make sure that we're not just putting posters up on the wall that say we don't tolerate this and we don't tolerate that, and putting up the rainbow flag around LGBT and stuff like that. But we're actually really thinking about, what does it mean to work in this organisation, and how do I make sure that it's an organisation that is a place that everybody wants to belong. And so by virtue of that, I think that also puts us in another space. And so I think there is something about, taking the bull by the horn and actually being brave enough to respond to patients, that we won't tolerate that kind of behaviour. And you'll have to think for yourselves around what some of those sanctions might be if that persists. But I think most people, if they're told that unacceptable behaviour won't be tolerated and there's some consequences of it, most people will stop and think. And there's probably something then about providing some education as part of that process, so making it clear why we don't think it's acceptable. And then the very last thing is actually, and I think that post-mortem can be done later on, is actually to speak with your staff who are people of colour who are experiencing these things, and asking them what, what could have been done differently to what we did now, so that we are all learning together. Let's not just make assumptions that how we've stepped in or what we've said has landed, because it's really important that we're all working together to break these issues down. And it's a growing phenomenon in our society. I think part of it has been, I remember when I was in Southampton actually, and we had a board meeting the day after the Brexit vote. And I came into work, and some of us were feeling quite sad because some of us didn't want us to come out of the EU. But I remember being at the board and being told a story by the chief nurse how one of, and I think it's, anyway, it was a nurse in Europe, I think a Mediterranean nurse, who went on the wards that night and was dealing with a patient, and the patient said to them, "Why are you still here?" And she just thought that he thought she was going off shift. So she said, "Oh, my shift hasn't ended yet." And he said, "No, we voted Brexit. Why are you still here?" And I mean, that was just absolutely horrible for that member of staff. We did a walkabout around the hospital, and it was just palpable how many of our staff were just feeling that they weren't welcomed. And this wasn't just staff from Europe, but actually some of our Black and Asian staff who were thinking, well, is this also about me? I'm not from Europe, but I'm visibly different. Are people also saying they don't want me here? So I think it's been a growing issue since the vote of Brexit. I think there's many things that contribute to it, and we therefore have to work collectively to undo that.
Absolutely, and stepping in and advocating for all of those that can't always advocate for themselves. Jenny, thank you so much. Really great talk and some fantastic questions and answers. Thank you to the audience for those questions, because it's that interaction that's brilliant. I want to give you a massive round of applause.
Thank you.
Selection of us in the room, but I know people will be really grateful. We can leave you to get off to your race ahead, but we've got one more bit of our session. But I know you're keen to get off to support the race ahead, and really good luck with that. And once again, to the audience, please do look at the race ahead work that Jenny's leading. So thank you so much, Jenny.
Thank you very much, and have a good day.
Thank you. Bye.
Bye.
So our third speaker in this session is Luke Bramall, and Luke's from the Children's North East, which is the oldest regional children's charity in the north of England. And this year they celebrate their 130th birthday. And the charity's consistently worked to tackle inequalities, disadvantage and poverty. And in keeping with its mission, 10 years ago, they launched the poverty proofing model. And now they've led that work across the country. So a real example of something that started locally, tested, worked, improved, and then spread. So real bit of improvement. And so I'm delighted that Luke, who's the head of youth services and poverty proofing, is here with us to share his learning and their experiences to date on this groundbreaking initiative. So Luke, really welcome, and really looking forward to this session. So thank you. Over to you.
Fab, thank you very much, Kate, and hello everybody. Kind of coming live from Newcastle, not in a boardroom like Kate, unfortunately. We've transformed a stationery cupboard into a Zoom room. So I come from a stationery cupboard in Newcastle. But anyway, let me tell you a little bit about what I'm going to do over the next kind of 15 or so minutes. I'm going to talk about this term poverty proofing. Really excited to bring you this kind of concept. But before we do that, I'm just going to kind of touch on poverty and what we mean by poverty, okay? And hopefully by the end of today, you'll see something of hope, optimism, and opportunity to be able to support those families that we work with, that we serve, that are living and suffering the effects of poverty. So as Kate said, I come from a regional charity called Children North East. As much as we are a regional charity in terms of poverty proofing, we lead on that agenda nationally. And you'll see a little bit about that as we come on to talk about that shortly. So let me, without further ado, just give us a kind of a baseline in terms of what we're talking about in relation to poverty, the first word on your screen, and then we'll come on to poverty proofing. So there we go. The slides are working. So first of all, I need to be really clear about what I mean by that term poverty. So the government definition of poverty is if your household income is less than 60% of the median income. We have variations, however, when we look at that term poverty. So we have, and you'll have heard, absolute versus relative poverty. Actually, when we go into sector-specific areas, people measure disadvantage and poverty in different ways. In schools, we use free school meal. In cultural organisations, we use fancy terms, kaleidoscope creativity as a measure of our poverty. So let me be really clear about what I mean by that term poverty. So if you're living in poverty, then you consider to lack the resources to have the types of diet, participate in the activities, and have the living conditions that's deemed kind of normal or expected within your community and within your society. So if you can't afford to take part in your society because of a lack of finances, then you're considered to be living in poverty. And very clearly, the reason we use that is because what we recognize is poverty impacts places differently. And what this does is takes the context of place, front and center. And that's not just me using this term. Organizations such as Child Poverty Action Group, Joseph Rowntree Foundation, and other national charities that campaign on poverty do the same. So that's what we mean by poverty. Let's look at some of those stats. And there's just a couple of these I just want to particularly highlight. Obviously, we don't really have any data from since COVID has hit. So the latest data we've got is really kind of up until 2020. And at that point, what we're talking about is that 4.3 million children across the UK are living in poverty. I always kind of feel like I need to let's just pause on that. 4.3 million children day by day are suffering the effects of poverty across our country. And actually what the Institute for Fiscal Studies does is predicting is that that's going to rise. So, because of the delay in time, if we're talking about 3 or 4 years, that might be up to a number as high as 5.2 million children. So no matter how poverty is affecting what we do in our workplaces now, within our work and the children and families that we support, what we can anticipate is that it's going to be an increasing issue. So that's kind of the headline kind of stats around that, and we can break that down. So we can look at Black minority ethnic groups. I need to get my terminology right there, and thanks to Jenny for that, it was really informative. 46% of children from minority ethnic groups are living in poverty compared to 26% of white British. Fascinating that 75% of children living in poverty come from working households. Massive figures and very different, and some of the other kind of intersectionality of poverty here in front of us, and much of this may surprise or may not surprise some of you based on your experiences. But what I'm really interested in, and this is kind of feeds into the poverty proofing approach, is well, what are the consequences of that poverty? Thinking in terms of your workplace, in terms of your work day to day, what are the consequences of the poverty that you see? And just to give a real kind of snapshot overview of what we know, well, we know there are significant health inequalities for those individuals living in poverty. We know that has significant impact in infant mortality between the most affluent and most deprived communities. We know that you're much more likely to suffer from asthma and diabetes. We know that it has an impact on tooth decay. We know it links to obesity levels. We know, if we talk about kind of life expectancy, it's a Northeast statistic, you have to bear with me, but the statistic that if you are a male living in a ward in Stockton, which is one of the local authorities in the Northeast, and there'll be others much more local to you guys, equivalent. If you're a male living in that area, then your life expectancy, if you're living in poverty, is on par with the life expectancy of a male in Ethiopia. Poverty in this country is having a real significant impact. And in actual fact, you guys will know this. You will probably see this within your work day to day. And we know that that's going to be the case. We could look at poor housing. So over 8 million people that are living in housing that's deemed unfit, whether that's overcrowding or unsafe accommodation. We've seen this massive issues around food insecurity, and then particularly at pressure points within the year. Summer holidays, massive challenges for families, and we see the impact of this on education, on social opportunities, of cultural opportunities, and this kind of negative stigma attached to being poor or living in poverty. So these are the consequences, and we have to touch. We know COVID has impacted on that. This picture is really clear. We've all kind of been in the same storm, but all had different boats to get us through it, and that's kind of very, and we've seen this widening of inequalities. Many families really struggling financially, and many really actually finding it helpful in terms of their finances. And there's various reports, but we're yet to see the true impact of poverty as a result of COVID. So what we find, just to kind of sum up what I'm wanting to kind of highlight here, is that poverty is having a significant impact within our families, within the children, within our communities. And people find themselves trapped, and this is a graphic by Joseph Rowntree Foundation, as to some of those reasons as to why families are just trapped and stuck in poverty. And actually increasing numbers of individuals are in that kind of precarious, if you like, situation. Now, this is bleak. Everything I've said to you so far is, well, it's really quite bleak. And I recognise that, and to some extent unapologetic about that. But what this graph kind of depicts, and what this next kind of quote depicts, is something that can allow us an opportunity to hope and to be optimistic. In that poverty is not an accident. Poverty is like slavery and apartheid. It's man-made, it's person-made, and can be removed. Poverty is a consequence of the structures of society, therefore it is not inevitable. And while we can't change everything linked to poverty overnight, what that does is that gives us a theory, a basis, a way of working, a way of thinking about our day-to-day practice that can inform the way that we best support those families living in poverty. And I'll come on to that now as we talk about poverty proofing. So please hold on to some hope there. So poverty proofing. Poverty proofing actually started in schools. It started 10 years ago. We did a consultation across the region of the Northeast, and we gave out disposable cameras, said, take pictures of what poverty looks like to you. It's a really kind of fascinating consultation. As you can imagine, we got 11,000 photos. We went back to those children and young people and said, well, what can we do as a charity to tackle this poverty that you have a unique insight into? And the response was clear. The one place it's miserable to be poor is school. So let me just tell you about that journey before we come on to health settings journey. So we went into schools and spoke to children and young people. It's what we know how to do best as a charity, I guess. And what we found is that children were routinely every day facing some form of, for want of a better term, stigma and discrimination, unintentional stigma and discrimination, as a result of some of the structures of the school day. Children able to identify who's eligible for free school meals because it says FSM in the register, or you go on a school trip and you get the brown or white paper bag. Children talking of not being able to complete their homework because they don't have the resources at home to be able to do that. And sometimes schools providing resources, but doing it in such a way that was really obvious. So, if you got food for food technology and the school paid for it because you were struggling or were eligible for pupil premium or free school meals, then you would have to walk to the front of class. And children talking of the, if you like, the shame attached to that. And extracurricular was fascinating because children were saying, well, we can't go on trips because of cost, but actually sometimes we can go on the trips because the school will pay, but all our friends are taking loads of spending money or can get the £10 queue jumper pass, and we can't afford that. Or not going to the free after school football club because everybody's wearing the latest football kit. We don't have the latest football kit, so children saying, well, I'm just not going. And it really feeding right into the conversations that were happening in class, after Christmas, what did everyone get for Christmas, or after holidays, where did everyone go on holiday? Write about where you went. So children facing these kind of, and hopefully from those examples, what you get is this kind of lens, this poverty proofing lens, as I would describe it. What is the experience of what I'm doing here and now like through the lens of a child or a family or an individual living and suffering the effects of poverty? So poverty proofing the school day was born, but 5 years ago we started conversations with other sectors who were saying, well, do you know what, how do we poverty proof what we do? And so what we did is we took these kind of core principles of poverty proofing, and hopefully as we talk to this, you might start to see some of the correlation within your day-to-day work. And the principles are quite clear. I've talked about pretty much all of them already. taking the voice of those affected, our patients, our school children, our beneficiaries, and listening to their experiences and what are those real barriers. And we heard from some children earlier in the video how powerful, but listening to people, understanding the context and the place within which people live and the poverty that they're experiencing, but ultimately using that voice and that context to inform the policies, the processes, the structures and the systems within which we deliver our work. And so we adapted that, taking those core principles to other sectors, and we could talk about, we've taken it to employers. We are working with cultural organisations, but I'm just going to kind of flip straight on to what we've done within health settings. We took that model and essentially initially we carried out what we called a pre-poverty proofing health settings piece of work across North East and North Cumbria in conjunction with the NENC Child Health and Wellbeing Network. Okay. And we went out and we spoke to families, to children, to young people, and I mean to individuals. And we kind of pose this question, well, in terms of accessing health settings, what are the challenges that you face? And we weren't surprised by this necessarily, but by applying that poverty proofing lens to health settings, we found already a raft of challenges that individual patients, individual families were facing in accessing the health provision that was there. And so some of the key headlines, and I can share the report in the chat after. Transport, massive challenges. Families talking about having to get 2 buses to get to an appointment and then 2 buses back, but actually the buses were from different bus companies, so they had to pay for 2-day passes. I don't need to tell people about the impact of parking, whether that's the cost of parking, at a hospital site, or whether that's just actually finding somewhere to park within a GP surgery, within a local community. Some of the, challenges around appointment times and when appointment times were happening. And because many people were on low income wages or jobs, shift work, 0-hour contracts, that having a real impact on their ability to attend appointments at certain times, and therefore having to cancel and foregoing that because they know if they miss their work, then they are going to end up really struggling kind of in the next month. Phone and video appointments being really good for some people actually in terms of access. Real challenges around that digital divide, which I don't need to talk about. What's really fascinating about this was particularly families where English was an additional language. They found this engagement really, really difficult. And again, missing appointments, missing opportunities for that healthcare and support. The one health setting that came out as the hardest to access, hospitals, and just the multifaceted challenges that individuals were facing. Their access to food, if you're going into a hospital, the access that you might have to food, or the cost of food. And us speaking to many parents of children who were not able to eat because they weren't able to access food within the ward, and they couldn't afford the food that was available to them, and no access to family providing it. And particularly really interesting we found that it was most difficult for those with long-term conditions and disabilities. But this is just a snapshot of some of those issues, some of those things that we found kind of routinely that was being faced through kind of health settings, and that was very broad. We're now currently working and applying that poverty proofing lens in terms of what is it that our setup, our processes, our structures do that may make it more difficult for those living in poverty. We're currently working with a maternity department in a hospital in Warwickshire. We're currently poverty proofing paediatric diabetes team up here in the northeast. We're looking at working with some GP surgeries, and what's really important about that is we're going and we're speaking to people. And if there's one thing I would encourage you to do, it's to put on the poverty proofing lens. Yes, absolutely. But it's to speak to those affected. Where are the challenges? Let's have some open and honest conversations of what is stopping you being able to access the important and valuable healthcare that you need. So let me, so there's two things here in terms of health settings. One, there's a practice of poverty proofing. It's a practice that, and something that we are continuing to roll out across different departments, services, so we can build on the learning we've had so far. And, it'd be great for you guys to be involved in that journey. But there's something ultimately of an ethos here. And looking through the lens of, a child or an individual living or suffering the effects of poverty. And please, if nothing else, I'd encourage you to do that. So let's apply the poverty proofing mission to your work so that no activity or planned activity in your health setting will identify, exclude, treat differently, or make assumptions about the babies, children, young people and families whose household income or resources are lower than others. And I'm sure you look at that and think, of course, that's what we want. Let's see how we can kind of learn from what's out there. As I say, I will share that document in the chat after. So let me just kind of final point. Poverty proofing, you may have seen this before, but it really brings it home for me in terms of poverty proofing. There's this big old fence in the way for these children accessing this game, this opportunity. So we talk about equality. We will provide the boxes so everybody can see. But I guess there's something here about, let's go one step further. Let's look at the design of our services so that we can get rid of the barrier altogether. And I kind of dislike the fact that there's still a fence there. But what we're calling for here is some justice, that our services can be open and accessible to everybody. And as I say, the most powerful way of doing that is speak to those affected by poverty. Final thought, Patch Adams may be controversial, but I love the quote. Excellence in health means devoting your life to ending poverty, and certainly that's where my heart is at. So I will click on. Please get in touch. Please, I will share the document if you've got any further details. It's got details on there of us and also our colleagues at the Child Health and Wellbeing Network in North East North Cumbria. But happy to take any questions if there's time, Kate. I'm conscious that time is ticking. But please do take my details there and I will stop sharing shortly.
Brilliant, Luke, amazing. Your 20 minutes, I think, like literally timed to the seconds. That was fabulous. Thank you so much. And just here in the room, we're like, oh yeah, that, what about this? We're having a great little chat here. I haven't been able to see the chat on the conference chat, but there's some questions coming up on Slido, which I think are really helpful. So first of all, I'd just love to do a quick poll. So I haven't got time to set up a poll now, but can people just do it by putting a hand up on the chat? Somebody said, who asked whether families consider themselves poor by whatever definition as part of their history taking? We're so used now to asking all kinds of screening questions. I have to say, I'll put my hand up and say, I don't ever ask, do you consider yourself poor? But does anybody ask if they consider themselves poor as part of the history taking? That was just a quick poll out there to the audience. And people that do, it would be really good to just see in the chat any kind of tips, because I'm sure, as you say, Luke, it's about going out and asking those people, how do they want to be asked that question? Because actually, we're used to asking the question, have you got a social worker? But having asked that question for 20 years, I still sometimes feel a bit embarrassed about asking, have you got a social worker, to somebody? So yeah, that's a great question.
It's a really difficult one as well, Kate, and just to come in terms of what it is that we talk about when we're carrying out our consultation. Poverty is loaded. Now, I don't hide away from the term poverty because I know that there can be shame attached to it, but actually there's something of claiming this is what it is, and families are really suffering as a result of the poverty that they're facing. So I don't want to kind of hide away from that term, but in conversations, individual conversations with patients or individuals, quite often refer to kind of the idea of struggling with money. It's a much more accessible term, and one that kind of people can relate to, because most people living in poverty would not consider themselves to be living in poverty. So that's how we kind of talk about that in relation to.
So yeah, struggling with money, like that term. And somebody's put, Katrina, whether child receives free school meals. And interesting, because we're having that exact debate. We're in the position, we've got some charity funding. I'm running the epilepsy service here. I'm wanting to provide free sleep safe pillows for those children that might not otherwise be able to afford them. And we were thinking of exactly that question, is if they're in receipt of free school meals, then we would provide their charity. Have you got any thoughts on that?
I do. It's a really interesting one. So free school meals, I think it's a very kind of it's a good way to ask the question, but what we've got to be aware of is that free school meals is a bit of a defunct measure when we talk about poverty. So the latest research that and we've been part of with the Child Poverty Action Group would suggest that nationally, the full national data hasn't been completed. It has in Wales and in the northeast, but we're looking at across the country, 2 in 5 children living in poverty are not eligible for free school meals because of the eligibility criteria. So I think it is a good, I would certainly say that's not a bad way of bringing it up, because it's a non-threatening way of kind of posing the question, but there's got to be an understanding and awareness around that.
Yeah. Okay. And then the final question was, again, this is a practical thing, how might people identify families that should be providing food for the parents as well as the patients? So, similar, but any thoughts on how people might actually practically identify some families?
I think there's something about the kind of the question, and that in building that relationship while looking into kind of history and such, like how asking something around that. I think that's very kind of possible. What we've seen work in a lot of kind of areas, because it's really difficult, because what we're trying to do is identify something when people don't have a badge, and which is good. And ultimately, I guess my purist kind of poverty proofing sense is, well, we need to look at a structure that allows people to access food in some way, shape or form, or at least be offered that food. So that's my kind of purist answer. That's a very much more complex one when you really kind of dig into it. But I think that there's nothing wrong in my mind of, first of all, there needs to be an awareness around poverty, but there's something about kind of, are there certain triggers or certain things that make us think as professionals, this family might be struggling? So that might be comments that the children make. It might be that in conversation, one of the parents has said, oh, I've been made redundant recently, or, it can be some of these kind of key trigger points. And I know staff team in a variety of organizations, whether it be schools, cultural organizations particularly, have highlighted, they've kind of come up with some kind of trigger moments or things, whether it's certain kind of dress or changes in people's appearance over time. And certainly if there's those families that we're engaging with regularly over time, if there's a change in appearance, that can be a trigger point. Or maybe we need to just kind of highlight this or address this. So the key thing for me is there's a process there, though.
Yeah, and we're thinking about it. We're starting to ask the questions. So, Luke, thank you so much. Really brilliant for you to join us. If you can share that article in the chat, there's a few other questions coming up you might be able to just respond to in the chat on the conference. That would be lovely. Really grateful, Luke, for you giving us time from your amazing stationery cupboard.
Thank you.
Everybody's welcome wherever they're coming from. We're just going to close the session by coming back to young people again, and they are going to talk to us about how we can support their engagement in healthcare. And Emma, I don't know whether you want to just say a couple of words to introduce this. There will still be plenty of time for people to grab a coffee, a quick walk in the garden, and to register for the workshop. So don't worry, it's not a long video, but it's a really nice way to end this session. So Emma, over to you.
Thank you. Yeah, so again, some brilliant things that have already been covered by the two speakers, which again, you will hear come up from some of the suggestions from the young people in this next video. They have contributed lots of ideas and voices, and we've got lots more that have come through our other projects. But really, as we've already said, it's about thinking through some of those choices. And there's one bit in the video which looks at choice, where you'll see there's two different views as to how a health service has supported them during the pandemic. And I think it just goes back to what you've just heard around virtual conversations and virtual consultations even. So have a look out for that, and then I'll pick up at the end of the video. Accessibility in Health by Demi, age 16. Accessibility is important to me because I have experienced the frustration of not being able to do something without planning it first. I know firsthand how it can impact a person and their family's daily life too. My older brother is deaf and has cerebral palsy, so it's something I've witnessed on a daily basis. Having to ask questions like, is there access via a loop system? Or can he access that with limited mobility? Or can we do it together or independently? But the answer isn't always yes. Accessibility has different meanings depending on who you ask. However, I believe that accessibility is inclusion for everyone, always with the adaptations and flexibility being available to all. Communication is another factor of accessibility, as well as because people have the right to ask questions and be heard, using the language that works for them, whether this is via a translator, communicator, symbols, subtitles, so accessibility has many factors. For the RCPCH Annual Conference 2021, Dr. Fizz and I met and spoke about accessibility and some of its advantages, as well as its flaws. In our interview, we spoke honestly about our life experiences, and she explained the difficulties she has faced through COVID-19, and before with being deaf and having full communication access. I can't comprehend why it has taken so long to be able to wear clear face masks. This would help patients and health staff, not just who are deaf, but also who have learning disabilities, English as a second language and other things. I think everywhere needs to have a 3-point plan that they use to check their accessibility, in a project, in a clinic, or in other parts of life. This could include, number 1, check their communication needs. Do they need a voiceover, subtitles, large print, or pictures? Number 2, check their age and stage ability. Do they need an easy read version, someone to explain it? Number 3, check their access needs. How can they get to see you in person or online with as much independence and dignity as possible? Have a think about this 3-point plan and see what you can do in your team to make it more accessible to patients, families and staff. Thank you for listening. On behalf of Demi.
Hi, my name is Hamna and I am 12 years old, and I've been volunteering with Anders for around a year now. As someone who has asthma, I feel like lockdown has really affected me. No hospital appointments, no school, and nobody to take care of my medication or any of my problems relating to my asthma. This has caused me to worry and become anxious. Who could I talk to? During lockdown, I had one appointment with my asthma doctor, which was a virtual appointment over the phone. I found this is very strange, not having any tests to check how my asthma was, and only having to answer how my asthma was. It was my mum who answered most of the questions for the rest of the appointment, which doesn't usually happen during the face-to-face appointments. Perhaps if a virtual appointment could have been a video call, that probably would have helped me feel more comfortable and connected. Being in a high-risk category, I felt that I had no one to talk to about my concerns and worries, and I was extremely worried when I started going back to school due to my asthma.
Hi, I'm Jamie. I'm 12 years old and I come from Liverpool. I would like to talk to you about virtual appointments. Whilst on lockdown, my appointments became virtual and on WhatsApp. I find that great, no need to wait. The only problem, I couldn't go to Costa Coffee. I think virtual appointments are the way out forward, as no stress on the parents or patient, no having to find someone to sit with siblings. Best of all, no waiting.
So overall, when I think about our experience as a group, the most important thing for me that came out of it was that we were all given a space to kind of learn as we went along, and we were given a lot of space for creativity. We didn't exactly know how everything would work from the beginning, but we learnt a lot by staying open-minded throughout.
A top tip would be to keep an open mind throughout the project and adopt ways of working which work best for the group. There's no set rules on how to have an effective meeting, and there's lots of different ways to make sure members feel supported when it comes to mental health and well-being. So it's just important to do what works for everyone involved.
When seeking to engage young people, never patronise and always explain the value of the work we'll be doing. This also means engaging us from the offset by allowing us to identify the problem, target an audience, and show them that our solution is implementable. Inspire us by continually asking why and getting us to think deeper and more specifically about the problems we're challenged with.
I've broken down what you can do into 3 steps. The first is to let young people know he is a safe adult they can trust and come and talk to if they have things going on at home. This could be implemented by going into school councils and youth clubs and asking young people for help creating youth-friendly resources that explain this. These posters could then be put up in waiting areas and in areas young people spend their time. The second step is get young people involved in supporting your services. You could do this by having a youth-specific patient participation group meeting where young people can advise on issues. Another way to get young people involved is to have a look at the You're Welcome guidance. You can then use this guidance to see how youth-friendly your service is and act on where you can improve. The third step is get skilled up. The first way you could do this is by signposting to up-to-date resources that cover a range of youth safeguarding topics like mental health, sexual health, young carers, LGBTQ+, care leavers and services for disabled young people. A second way to get more skills is to look at the different ways young people want to connect with their primary care network. This could include text messages and emails, and making sure young people are in a private space before having an online appointment. A third way to get skilled up is to attend training on communication skills. Examples of this include the Me First and We Can Talk training. Thank you for listening. Please now ask Emma if you have any questions.
So you can see from that last video then some of the similar themes that you've heard from all the speakers this morning. So to really concentrate on the right communication tools and methods for children and young people so that they can share their experiences, whether it's about living in poverty, about how different things are affecting their health, or actually about maybe exploring different identities for themselves and wanting to do that with you without maybe their parents hearing, which is really difficult in virtual appointments. And we've heard that time and time again across our work. The choice, so you had one young person saying that they really didn't necessarily get on that well with virtual appointments and it made them feel a little bit more anxious that they couldn't see people or talk to them or have some of their tests that they're used to having. And another young person saying actually virtual was working so much better because it relieved lots of the stress. So just like you've heard from the other speakers, it's really important that we just ask all of our community groups and do create some very personalised approaches, which goes to the third key point that came out from RCPCH and us about being flexible. And that is for children and young people, so that we can really give them person-centred care and provide health services that meet their needs, but also be flexible with ourselves. So to ask people, to get peer support, to explore things, to develop our own skills, so that we are able to both understand the different types of backgrounds that children and young people are having at the moment and creating and learning and developing, and to understand that actually they might change in terms of how they identify through the course of their health journey with you, but also to think through how actually we can really support them to get the best health possible and the best health services possible, which, as we know, is part of the United Nations Convention on Rights of the Child, Article 24, and Article 12 is their right for their views and opinions to affect the decisions that have an impact on them. So, it all goes back down to, as they always say to us, just ask, and then we can help to develop it together. So if there are any questions, then, I can answer them in the chat, because I know that it would be good for everyone to get a coffee. But also we've got lots of different resources that you can access from RCPCH and us, which I'll drop the link into the chat as well. But yeah, that's it from the children and young people. Thanks for inviting them to take part.
Thank you, Emma, and please pass on our thanks to all the young people that took part in taking those making those videos and inputting their thoughts and ideas. We're always super grateful for you really supporting the peer conference and bringing those voices.